Ahead and start. All right, again, welcome everyone. My name is Jennifer Howard. I'm the director of the Turner Senior Wellness Program. It is my pleasure to present nurse practitioner Sarah Redies from Turner Geriatric Clinic. And she is here to present on diabetes management, reviewing the basics and newest updates in care. Sarah, I'm going to turn everything over to you.
All right. Hi. Thanks everybody for joining. I am one of the nurse practitioners at the geriatric clinic. I primarily do primary care, but 4 hours a week I work with one of our endocrinologists and do geriatric diabetes management. So primarily what I'm seeing in that role is type 2 diabetes, which is what I'm going to focus mostly on in this presentation. So like Jennifer said, there are some kind of natural pauses in the presentation so we can stop and ask questions before we move on. I kind of geared this towards people who are maybe new to diabetes or maybe have family members who have diabetes and maybe don't know much about it themselves. So hopefully this isn't too basic for everybody. And then in the second half of the presentation, I talk about some of the new updates with medications and technology. And some of that is pretty cool and exciting. So hopefully that is relatively new for most people listening in on this. So we'll go ahead and get started. So real kind of basic here is what exactly is diabetes, and to understand that you have to understand the relationship between sugar and insulin in the body. To put it super basic, when we eat, the food that we eat is turned into glucose or sugar and then is released out into the bloodstream, and then the pancreas is triggered to release insulin. And the insulin works kind of like a key to allow the sugar to enter the cells into the body, and then the body uses that as our energy source. So that is how it works for everybody's body. And here's kind of a quick little visual of the exact same thing that I just said. Basically, as the sugar rises, the body's triggered to make insulin. But in diabetes, that is a chronic medical condition where the body either doesn't make enough insulin or cannot use the insulin it makes as well as it should. So I'll talk more in detail in an upcoming slide. But big difference between type 1 and type 2 diabetes is type 1 diabetics don't make insulin, which is why they have to take insulin, where type 2 diabetes is often related to insulin resistance, or where they're still making some insulin, but not enough. And so we can use either pills or other medications or insulin to help control that. Because we're not using insulin well or making enough insulin, this thing causes too much sugar to build up in the bloodstream. And over time, that can lead to serious health problems. Things like heart disease, nerve damage, vision loss, kidney disease. These are the common complications that you've probably heard of with regard to type 2 diabetes. So again, here's just some more information about the difference between type 1 and type 2. Type 1 diabetes is an autoimmune reaction, and that causes the body to stop making insulin. So therefore, people have to take insulin if they have type 1 diabetes. Was previously known as juvenile diabetes because it does usually pop up at an earlier stage in life, usually in childhood, young adulthood, although we are seeing type 1 diabetes develop later in life as well. Type 2 diabetes is by far the most common type of diabetes, and it causes the body to not use the insulin well or not create as much insulin, but still creating some insulin, which then causes the sugar levels in the body to rise. Important things to note is that this can be prevented or delayed with healthy lifestyle changes, and we will talk a little bit more about that briefly, and I'm not going to talk about this at all otherwise in the presentation, but there is gestational diabetes, which develops in pregnant women who have never had diabetes before and usually goes away after the baby is born. So we'll focus mostly on type 2 diabetes for the rest of the presentation. There are some pretty common risk factors for type 2 diabetes, and I'm sure most people know most of these. Number one is prediabetes. So a lot of people have prediabetes and don't know. And I do have a slide about that coming up, but that is a very important risk factor for then going on to develop type 2 diabetes. Being overweight, being physically active less than 3 times per week, being over the age of 45, definitely having a family history of other family members who have type 2 diabetes, having a personal history of gestational diabetes, or people who are African American, Hispanic, Latino, American Indian, or Alaskan Native are at higher risk for developing type 2 diabetes. So we can talk briefly about symptoms, but by far and wide, most people with diabetes do not have symptoms. With type 2 diabetes, do not have symptoms. And often people live for years with diabetes and don't know they have it. We often pick up on it just from a routine screening, such as routine lab work where the blood sugar is elevated and then prompts us to do some more evaluation. But in instances where the sugar is very high, we may see symptoms, which are listed here, but increased urination, excessive thirst or hunger, unintentional weight loss, vision changes, numbness or tingling of the feet or hands, fatigue, skin changes, wounds or sores that are slow to heal, and frequent infections. This is usually when the sugar is very high, though. So when we're seeing kind of the beginnings of diabetes, usually people have absolutely no symptoms at all, and we pick up on it on lab work, like I said. So I do want to talk about prediabetes because it is very important, and I don't think we do a great job in the primary care medical world of explaining this, especially for seniors. But prediabetes would be where the blood sugar is elevated, but not to the degree where we can call it diabetes. And we often go off of the A1C. So an A1C that is less than 6.5%, but above 5.7% is considered to be prediabetes. It greatly increases the risk of developing type 2 diabetes in the future. So what is important in prediabetes is, one, that we keep an eye on it and make sure that we're checking it every 3 to 6 months, or at least once a year, to make sure that it hasn't progressed on to type 2 diabetes. But also it's important to know that with lifestyle changes, we can greatly reduce the risk of developing type 2 diabetes. So as it says here, approximately 1 in 3 adults have prediabetes, but a huge majority of them, about 84% of people with prediabetes, have no idea that they have it. And there is a National Diabetes Prevention Program, and you can look up information about this on the CDC website. I know that the YMCA in Ann Arbor, at least pre-COVID, had a diabetes prevention program through that was accredited, and that has been studied and shown to reduce the risk of developing type 2 diabetes by 58%. So in that program, they focus on things like nutrition, lifestyle, exercise, to prevent people from then going on to develop type 2 diabetes. So talking about the management and treatment of diabetes, I'm going to first talk about the non-medicine things, and then we can talk about medications. First and foremost, diagnosed with diabetes or pre-diabetes, it is really important to continue to work closely with the healthcare provider to monitor and manage the disease. Most of the time, a primary care provider is more than capable of managing type 2 diabetes, especially early on in the disease. But in some cases, when the management becomes more difficult, more complex, then primary care providers will involve a specialist, an endocrinologist. So that's when I work with the endocrinologist in our office. It is from referrals from primary care providers for endocrine involvement in managing the diabetes. And it is often usually a joint venture between the primary care and the specialist. Instances where a primary care might do this is if somebody was on a pretty complicated medication, or more specifically a complicated insulin regimen where people are injecting insulin multiple times a day with varying doses, where it's just a lot to manage, where a specialist can handle that better. People who are having trouble tolerating medicines, having trouble finding a medication that the patient can take or that works well. And even primary care providers will involve endocrinology when people are having trouble with things like low blood sugars, which is a common reaction to some diabetes medications. The other real key for managing diabetes, and we definitely don't use it enough, is diabetes educators. So at Michigan Medicine, there's a whole department of diabetes education. which is comprised of nurses and nutritionists or dietitians. And they are closely linked in with the endocrinology department at U of M, but primary care providers can also refer patients to diabetes educators for help with managing diabetes. And they obviously do things like help with give nutrition advice, help come up with a meal plan, looking at somebody's nutrition and giving them advice on how they can make changes. They can help set goals or make lifestyle changes, things like exercise goals or getting more physically active. But they can also do a lot more specialized things. So at U of M, the diabetes educators are closely involved at actually looking at blood sugar numbers, and then can speak with the provider about their suggestions of things they think might help. Um, there are diabetes education classes. Again, with COVID, I think right now most of that is virtual, but previously a group of people either newly diagnosed with diabetes or maybe never had any formal education about it sit down for a weekly class for 4 weeks where they will go through all the basics, diet, medications, lifestyle, risk of complications, et cetera. So those are really good, but they can also do one-on-one education for people who maybe have um, hearing trouble, language barriers where they wouldn't do very well in a group class. They are also able to sit down one-on-one with people. And we also use them for some of the new technology things, which I will talk about later in the presentation, but we can refer people to the diabetes educators and they can teach them how to use some of the new technology, new glucose monitors. Type 1 diabetics are regularly involved with diabetes educators for things like insulin pumps. And they also can help us order some of these supplies that sometimes are tricky to get pushed through insurance or make sure we're getting them ordered right. So I use the diabetes educators a lot. I don't think a lot of other primary care providers do, but we're seeing more and more of it now that there is more technology and things are a little bit more complicated. And patients can always ask to talk with a diabetes educator if they have specific questions about things like nutrition, if they feel like they would benefit from a weekly class for 4 weeks to learn more about it. I definitely have had patients that have had diabetes for 10 or 20 years and just really feel like they didn't understand much about it. So I've referred them to the classes so that they can get a better understanding of their diagnosis. So talking more about the non-medication management here, and I'll be brief with this. We know diet is huge. Carbohydrates are what are the caveat of the diet for diabetes, and we always hear about low carb diets. It is more complicated than that, though, and that's why, if people do really need some more assistance with figuring out diet, getting in with a nutritionist, specifically one who is trained in diabetes nutrition, is really helpful. We can't just tell people to eat no carbs. We need carbs for our brains to work right, for our bodies to function right, but it is a balance between carbs and the other aspects of nutrition. So it can be fairly complicated, which is why it's good to even do a one-time visit with a nutritionist to get a handle on the nutrition. Physical activity is also a huge factor in type 2 diabetes. The current goal, which the CDC recommends, is 150 minutes of moderate intensity physical activity per week. So that would be things like a brisk walk where you could still talk with somebody, hold a conversation, but you're definitely working, or 75 minutes of a higher intensity physical activity. So that would be something like jogging. And then we know weight management is a huge factor in diabetes management as well. So the goal is to maintain a healthy BMI, but even losing 5 to 10 pounds can drastically improve diabetes and blood sugar control. Waist circumference is also another factor that we often don't talk a lot about, but there are recommendations through the CDC to keep the waist circumference below 35 inches for women and below 40 for men. That kind of abdominal weight gain is a higher risk factor for either developing diabetes or poor diabetes management. And then, of course, for when we think about managing diabetes, there is blood sugar monitoring. So it really depends. Certainly, a lot of people don't check their blood sugar and really don't need to. With certain medications, it's not really necessary. If we're not going to use the numbers that you're getting at home, why would we have you test them? But for some medications, insulin specifically, you really have to check your blood sugar to be safe. There are medications that cause the blood sugars to drop, so we need you to have the ability to check your blood sugar. And if we're having a hard time getting somebody under control, if we're trying to figure out if a medicine is working well, if people want to know what certain foods do to their blood sugar, if eating something always makes it go high and you want to have that feedback, then testing blood sugar at home is very important for a lot of people. And it is always a good safety thing to at least learn how to do it and make sure you at least have a glucose monitor at home. So that is something that you can work with your primary care. That is something that diabetes educators can certainly help with. And you can buy these over the counter, but Medicare and most private insurance will cover glucose monitors, and test strips, depending on the treatment that you're on for diabetes, will determine how many strips, how many lancets, how much supplies you get per month. But this stuff is available over the counter as well. The goals for blood sugars really vary a lot, especially for seniors. There's a lot of newer evidence coming out about goals for blood sugars and A1Cs for our senior patients, and not needing to push those quite as low anymore. But roughly a goal for a fasting blood sugar, which would be your blood sugar first thing in the morning after not eating overnight, would be somewhere between 80 and 130. And then a blood sugar about 2 hours after a meal, a good target is usually less than 180. For some patients, I'll target less than 200 for a couple of hours after a meal. The A1C is really kind of the gold standard test that we use to monitor blood sugar control. It's easy to get, any lab can run it. A lot of primary care offices, but definitely endocrinology offices, can do finger poke A1Cs, where they poke your finger and they run it in a machine and you get the results within 5 to 6 minutes. So whenever I see patients who are coming in specifically for diabetes, we get their A1C right when they come into the office, and then the result is ready before I even go in the room to see the patient. Super helpful to have that information right in front of us as we're talking, so we can say, hey, this looks great, we don't need to make any changes, or, oh, this is a little bit high, we need to talk about adjustments. The A1C basically gives us a good idea of blood sugar control over a 2 to 3 month period. It is on a different scale than a blood sugar. And the goal we're looking at for most seniors is usually somewhere between 7 and 8.5%. We no longer target below 7% for people over 65. And sometimes we really loosen up those targets quite a bit for people who maybe have other health conditions, who are more advanced age. Reason for that is the lower we push the A1C, the higher the risk is for low blood sugars. And we know that low blood sugars can cause a lot of problems, especially in seniors. Even one low blood sugar can be very risky. And if blood sugars get low enough, they can be life-threatening. A lot of diabetes medicines can cause low blood sugar, so it is something we watch for. The other reason why we don't have to be so tight with the A1C in some patients is when we're looking at targeting a lower A1C, like closer to 7, what we're really looking for is improving the long-term outcomes. And for some people, it doesn't make sense to target long-term outcomes. If somebody has really advanced dementia, if somebody has, a cancer where that's limiting their life, we don't need to work on preventing longer-term complications. We're looking more in the short term. Additionally, conditions, things like Parkinson's disease, where people are at higher risk for things like falls, we're usually okay with a little bit higher A1C, because if they do target a lower A1C, again, higher risk for a low blood sugar, and that can increase the risk of falling and injury as well. So talking about diabetes related complications, these are really this is the reason why we want to try and keep diabetes under good control. We want to prevent complications from happening. The common ones that everybody's heard of, I think, are probably neuropathy or nerve damage. So specifically in the feet, You can get nerve damage though in many other places, like it says here, hands. You can get nerve damage that affects the bladder and can affect bladder control. You can get nerve damage that affects the digestive tract, which can impact diet, how you digest food, stomach issues, and you can get nerve damage that impacts sexual function. I think what people hear the most about is numbness, tingling, pain, pins and needles in the feet. And that is certainly a common thing that we see. That also increases the risk of developing things like wounds and sores in the feet, because if you don't have great sensation in your feet, you can get a sore there, not realize it, and then can lead to more problems. Probably the other most common things that people hear about are eye disease, which is retinopathy or damage to the blood vessels that feed the retinas of the eye. So in most severe cases can lead to blindness, but can impact vision for sure. And then kidney disease. So I think everybody has this fear with diabetes of needing to go on dialysis. Diabetes is the number one cause of chronic kidney disease, is one of the most common causes of chronic kidney disease in the country, as well as high blood pressure. And so it is another good reason to keep the blood sugars and the diabetes under really good control to prevent future kidney problems. Additionally, I think there are some things that maybe people don't realize diabetes impacts. We talked about the feet. Biggest risk there is developing wounds and sores, which in worst case scenarios can get infected and require pretty serious treatments. And in rare cases can lead to things like amputations, but it is not as common as I think what people hear about, but it definitely does happen. Hearing loss is actually a risk with diabetes. People with diabetes are almost 2 times as likely as people without diabetes to have hearing loss. Oral health, so diabetes increases the risk of gum disease, which then can increase the risk of things like tooth loss. So it's important to see a dentist regularly, especially if you have diabetes. And there is a higher correlation between diabetes and depression. People with diabetes are about 2 to 3 times as likely as the lay population to have depression. So it's important to continue to follow up regularly with a primary care provider and make sure that you let them know if you're having any concerns about mental health at all. Additionally, diabetes is a huge risk factor for things like heart disease, so heart attack, heart failure, and stroke. So keeping diabetes under control reduces that risk of those complications. When diabetes is under poor control, there is a higher risk of those complications. So when we talk about reducing the risk of complications, the common term is the ABCs of diabetes. Hopefully, if you have diabetes, you've heard this at least before. The A correlates with regular A1Cs, meaning we're watching this. You're following either with a primary care or an endocrinologist regularly, and we are working on keeping your blood sugars and your diabetes under good control. The B of the ABCs is blood pressure control. So I know we're talking about diabetes, but hand in hand goes blood pressure control. I often, even when I'm seeing patients specifically for their diabetes, make adjustments to their blood pressure medications when they come in, because it is such a huge risk factor for developing some of these complications that we talked about on the previous slide. The C correlates with cholesterol control. So the current guidelines are really every adult who has type 2 diabetes should be on a statin medication if they can take one. There are some rare exemptions if the cholesterol is really, really low. But for the most part, everybody with diabetes should be on a statin medication, and we should watch their cholesterol and make sure cholesterol is under control. And then smoking cessation. So if ever, nobody should smoke, we all know that, but specifically if you have diabetes, it greatly increases the risk of developing those complications on the previous slide. So if I have a diabetic patient who is smoking, I'm encouraging them every visit to work on cessation, referring them to the smoking cessation programs that we offer. So again, kind of circling back to those risk of complications here, as I said before, keeping up with regular medical care, seeing your primary care or your endocrinologist every 3 months if diabetes isn't at goal, or at least every 6 months if it is at goal. The recommendation is a dilated eye exam once a year. So either through an ophthalmologist, or I believe Medicare will cover it through an optometrist as long as they are dilating the eyes and billing correctly. Regular dental care, like I said, because of that risk of gum disease, and regular hearing testing, and keeping up with regular foot checks as well. So that can be done at the primary care office. Some people do see podiatrists. Um, and we also encourage people to consider getting regular foot care. So we have nurse practitioners in our office who do it, but a lot of people see podiatrists either locally or through, a bigger health system like U of M or St. Joe's, just because of that risk of developing wounds or sores on the feet if people are trimming their own toenails. Podiatrists can also help with things like calluses. Foot deformities can be fairly common in people with diabetes. So things like specialized footwear, fitted footwear, insoles, things like that, podiatry can help with. And we also, some of the other kind of screening and regular checks that we keep up with, at least once a year, checks of kidney function. Often we'll do it more frequently than that, but that would be a blood test to check kidney function as well as urine testing. And screenings for things like depression. So very commonly done now through most primary care offices, which is good. But like I said before, there is a higher risk of things like depression with diabetes. So we do want to screen for that. Other ways to reduce the risk of developing any complications from diabetes are to follow a healthy and diabetic friendly diet. Like I said, nutrition can be a huge factor at helping to figure out the right diet plan for you, maintaining a healthy weight, reducing or avoiding alcohol, getting regular physical activity. So that's that 150 minutes of moderate activity per week, and making sure you touch base with your medical provider if you're having any mental health concerns. And keeping up with things like vaccinations. We know that people with diabetes, especially if it's not well controlled, have a higher risk of complications from things like flu and pneumonias. So keeping up with vaccines is important. So before I talk about medication management, Jennifer, if you want to see if there's any questions, I can answer those. It's probably a good place to pause.
Okay, yes, great. I was actually just typing an answer to one of the questions, but one of the questions for you is there a test that measures long-term blood pressure similar to A1C?
No, not that I'm aware of. I know that cardiologists sometimes will use a like a continuous blood pressure cuff, and they'll send people home with it for a while. It's not something that I've seen done at our primary care office before, but we can kind of gauge things like blood pressure control based on certain lab values, kidney function, things like that.
Okay, great. There's another question that I'm answering through the typing about the recording of the session. I don't see any other questions. Again, if anybody has questions, please feel free to click on the Q&A icon at the bottom of your screen and type in your question, and it will be all queued up for the next time that Sarah takes a break. Okay, Sarah,
Oh,
you're all set to go.
all right. So I'll kind of delve into medication management. I'm not going into a lot of detail here because this is so personalized. But there are many different medications for diabetes. I'm going to talk specifically about a couple of the newer agents that have come out in the last couple of years, which have some pretty exciting things going on. But it is really a decision between the patient and the medical provider to determine what, if any, medication is used to manage diabetes. And what was said in the previous slides, often people can keep their diabetes under reasonable control through diet and lifestyle changes. I have a lot of people who are diabetics with an A1C of something like 6.8, which is considered diabetic, but they're not above that 7.0 mark. So we don't put them on medication. We feel like their risk of side effects, their risk of a low blood sugar, et cetera, is greater than the benefit from being on a medicine. So we will control it through a diet and lifestyle. But that is a decision that is made between the patient and their medical provider. In terms of the medicines that are available, everybody knows about insulin, and I won't talk too much about insulin, but there are lots of non-insulin treatments available. The non-insulin treatments that are available, most of them are pills, but there are some injectable options, which I will talk about. Insulin, I think I'll just kind of digress a little bit. Insulin is commonly a feared medication in diabetes, but it really doesn't have to be anymore. I didn't talk too much about it in my presentation at all, but the most common way that we're prescribing insulin now is using insulin pens, which looks just like a pen instead of the old school vial and syringe. They're really easy to use. You cue up the pen, basically it's got a knob on it, so you twist it to whatever dose of insulin you need. You screw a needle on the top, and then you can just pinch your skin and inject it right from the pen, take the needle off, dispose of it properly, and then you can use the pen again the next time. It's all sterile, it's easy, you can take it anywhere you need to go, portable, you can throw it in your purse, in your car. Pretty discreet. If you're out to dinner, you can just inject it right under the table. People don't really have to know. And the needles now for that are about the size of an eyelash. So it's really, really small, very easy to use. So I have a lot of people who will tell me visit after visit, I'm never going on insulin. I don't care what you say. I don't care how bad my control is. I'm never going to take it. And then we actually get out all the stuff and show them how to do it. And turns out it's actually pretty easy. You're already poking your finger. This is actually less painful than a finger poke for most people. So I'll leave it at that. I'm not really talking much about insulin. Beyond that, a lot of people do need to go on insulin at some point, even if they do everything right. A lot of times diabetes is a progressive disease. And despite best efforts with nutrition, with lifestyle changes, for some people it does progress and the control gets worse, and we do need to talk about insulin management. But there are other options that we'll talk about here that we often will start people with, and that's kind of the focus of medicines that I'll talk about. In addition to medicines that are prescribed specifically to control the blood sugar, there are other medications that we often prescribe to people with diabetes to control their other risk factors. So kind of like what I talked about earlier on in the presentation, statin medications are pretty much gold standard recommended for everybody with diabetes. But we also need to keep blood pressure under good control. So like I said, even though I'm seeing somebody for diabetes, I often am prescribing blood pressure medications to keep the blood pressure under control. And a lot of these medicines that we use for these other conditions like cholesterol and blood pressure have another benefit. So for example, some blood pressure medicines that we prescribe, they actually offer some kidney protection benefits. So we know that people with diabetes are at risk for developing kidney disease. If we prescribe one of these blood pressure medications that help to protect the kidney, then we are hopefully reducing their risk of developing kidney problems down the line. The statin medications have been shown to reduce the risk of heart attack and stroke, independent of the cholesterol lowering effects. So I'll briefly talk about medication safety, because this is a huge thing that I see, especially in the geriatric clinic, that I spend a lot of time talking about in geriatric endocrinology clinic. We know that all medications have risk of side effect, some more so than other. If a side effect occurs, it's important to talk to your medical provider right away. So in some instances, if it's a pretty serious side effect, you need to stop the medication. In some instances, if it's not quite as serious, maybe it's something that you can talk about or make adjustments. The number one example I'll give is metformin has classically been linked to stomach upset and diarrhea problems for a lot of people. However, I have a ton of people who take metformin and have absolutely no problem with it. But if somebody comes in and says, oh, I've been having this diarrhea, and they've been on metformin, even if they've been on it for years, it is often related to the metformin medication. It's important to talk about that and not just stop that medication abruptly, because sometimes we can reduce the dose and improve the side effects. Sometimes we can switch it to a different formulation of metformin, so still getting the same benefit of the medicine, but a different extended release formulation will often improve the diarrhea. However, if it's a medication where it's causing things like frequent low blood sugars, it's not something we're going to want you to stay on. So you need to call your medical provider right away so that you can talk about other options. And moving into that, then, some medicines can cause a risk of low blood sugars, some don't. So it's a good thing to clarify with your medical provider, but many of our diabetic medications can cause a low blood sugar. And we are often using more than one medication to help keep diabetes under control. And as we add more medications to the treatment plan, that risk of low blood sugars does go up as people are on more meds. Um, so if you're on any medicine that can cause a low blood sugar, you should have a glucometer at home, a glucose monitor, and should know how to use it. And you should also have a plan of how you would manage a low blood sugar if you get one. That's something that you and your medical provider should talk about. Um, the gold standard is if you have a symptom of a low, which can vary, but usually are things like shakiness, sweatiness, confusion, feeling really hungry, dizziness, to check a blood sugar. If it's low, which is considered less than 70 or 75, then to consume some fast acting sugar. So we usually recommend 4 ounces of juice, 4 ounces of regular soda. You could also use glucose tablets. You read the label, but it's usually 2 to 3 glucose tablets, and those are sold at any pharmacy over the counter. Or you can use something like a couple of lifesavers, and wait about 10 to 15 minutes and check the sugar again, make sure it's up. You also want to eat something that has a little bit more substance. So I usually tell people to have like half a peanut butter sandwich or something to then keep the sugar up, because that fast acting sugar will get out of the system pretty fast. I always provide this in writing to my patients, especially if they have if they're on insulin, so that they can put it on their fridge. If they have a low blood sugar, it's right in front of them. They know exactly what to do. But the thing that I want to talk the most about is medication errors. So medication errors are common in general. They're common in our senior patients because people are on a lot of medications in senior years for the most part. So it's best to have a plan in place to prevent this from occurring. Common things that I see are missed doses or double doses. So either forgot to take the medicines and just forgot to take them, or took your medicines, can't remember if you took them again a couple hours later. Now you've doubled up on your dose. Double doses increase the risk of low blood sugars. That's kind of the most acute problem. Missed doses, obviously, then we're going to see higher blood sugars. Another common mistake that I see is in people who are on 2 different types of insulin. So if somebody's on a long-acting insulin that they take once a day, and then short-acting insulin that they take a couple of times a day, I have had people mix those up. Usually people are on a much bigger dose of a long-acting insulin and smaller doses of short-acting. So if they mix those up, then they're taking a big dose of short-acting insulin, which definitely increases the risk of low blood sugars. A lot of people take their long-acting insulin at bedtime. So if they mix it up and they take their short-acting insulin and then go to sleep, there's a risk of having a low blood sugar in the middle of the night, which is more serious because you're not eating and you're sleeping. And if it doesn't wake you up out of sleep, can be very serious or life-threatening. So ways to kind of prevent these things from happening are to label or even keep the insulins in different places. You know, I keep this one on the counter and I keep this one in the bathroom, something like that. So it's less likely that you're going to mix them up. In terms of pill errors, the safest thing to do is to use a pill box. If there are issues with getting confused, having family members help with setting up the pill boxes, filling the pill boxes. If you're missing doses, setting alarms. There are pill boxes that alarm when it's time to take the medicines, or even just setting an alarm on your phone so you remember to take them. Having a family member call you each morning and say, hey, did you take your meds? But pill boxes are a way to kind of know if you fill it once a week, every Sunday you fill it, and then you go to take your pills on Monday and you can't remember if you took them or not already. If they're not in the box, then you already took them. So it's a way to have an extra safety check there. I want to provide a couple of examples of things I've seen in clinic. I was referred a patient who kept having high blood sugars despite increasing the long-acting insulin. By the time she came to see me, she was on a pretty hefty dose of long-acting insulin. Couldn't figure out why she wasn't responding at all to it. And after further questioning, she said she had been using the same pen of insulin for weeks, despite huge doses. There was no way she would have still been on the same pen of insulin after this many weeks. What had been happening is she wasn't actually ever pushing any insulin out of the pen, so she was injecting no insulin. If she would have then injected the amount of insulin that was prescribed to her, she would have absolutely had a low blood sugar. because she would have gone from no insulin to like 60 units of insulin a day. So we figured it out. We got her in with one of our nurses to teach her how to use the pen properly, reduced her dose a lot, and then ended up getting her blood sugars under good control. Like I said before, probably the other common thing that I see for low blood sugar is switching the long acting from the short acting. I have definitely seen that before, where people normally take 20 units of Lantus at night and take 5 units of short acting insulin with their meals. They accidentally take 20 units of their short acting insulin at bedtime and then wake up in the middle of the night with an extremely low blood sugar, and their family has to help them get it back up again. So those are common things that I see. Any questions about that before I move on to the new stuff? It's probably a good time to break.
Yeah, Sarah, there is a question that is, can you explain why certain people who are not heavy and rather thin have diabetes or type 2 diabetes?
Yeah, probably the biggest explanation for that is genetics. So this is complicated genetic stuff that we still don't have a good answer for. But we know there's a big genetic influence in type 2 diabetes as well as type 1 diabetes.
Okay, and that's the only question that I have at this time.
Okay. So this is kind of the fun, cool stuff here is the new updates. These are the continuous glucose monitors. These are the most common ones that I see. There are some other ones, but I'll talk about these. I think they're great. The one on your left side of the screen with the round dot on the arm, that is the Freestyle Libre continuous glucose monitor. And then the one on the right side of the screen with the longer sticker on the arm is the Dexcom. So what these devices do is they monitor the blood sugar all the time. So you wear them, that little device on the arm there is the sensor, and it's reading the blood sugar all the time. It has a small little catheter that goes into the skin, just under the skin, and reads capillary blood sugar, so similar to what it would read out of the finger. The reason really that we use these are for people who are on insulin and who are injecting insulin multiple times a day. So it offers that safety benefit of seeing the blood sugar all the time, but also less pokes of the finger. So in somebody who is on insulin with each meal plus a long acting insulin, they're usually checking their blood sugar 3 to 4 times a day. With these devices, they don't have to poke their finger for that. Medicare does cover these, but there are strict requirements. You have to be injecting insulin 3 times a day and checking the blood sugar 4 times a day for Medicare to cover these. Depending on the supply company where you get these from, you have to submit, for some places, you have to submit a blood sugar log. And it can be tricky to get these covered. So for most people, I send them over to diabetes education. They talk to them about these, make sure this is what they want to use, and then they will help us to get them ordered through the insurance so we can get them covered. They are super helpful for tracking both the effects of the insulin as well as the effects of food throughout the course of the day. So, you eat a meal and then you can follow the blood sugars on these monitors and see how it changes based on how much insulin you took and what you ate. Big differences between the two: the Freestyle Libre, which is the one with the round sensor on it, you have to scan it, and probably a lot of people have seen the commercial for it. Basically, you hold up this little reader device to it and it'll then pop up a blood sugar on the screen. Where the Dexcom, the one with the longer sensor, is constantly giving readings, and they just show up on that reader, which just has to be within a certain distance of the sensor. I can't remember how far for it to read it constantly. The Libre, the round one, does read the blood sugar all the time, but I tell people to kind of think about it as like a small computer on the arm. It can only hold the data for 8 hours. So as long as you scan it every 8 hours, it'll then send all that data from the little sensor into the monitor, and then we can pull it up when you come into the office and look at a graph of what your blood sugar is doing all day long. But if you wait 10 hours in between scanning, we're going to lose 2 hours of data. So it can only hold 8 hours of data at a time. You got to pull the data off every 8 hours. The Dexcom, you don't have to do that. It stores the data all the time. It's always there. The Libre, the round one, the sensor is good for 14 days. So it comes with like an insertion kit. You do it all at home. And you just have to switch the sensor every 14 days. The Dexcom is every 10 days. People do have issues with these things falling off early, and the sensors are kind of expensive. We usually tell people to then reach out to the companies themselves, and they'll usually give you some sort of, they'll cover the replacement for the sensor or something, so you don't have to pay out of pocket for it. The Dexcom is linked for a lot of type 1 diabetics are using the Dexcom now because it actually links up with certain insulin pump. And so there's kind of some safety factors with that. I won't go into that too much, but the Dexcom will alarm if the blood sugar is starting to go low or if it's low. So it can actually wake people up at night if their blood sugar is starting to get to a dangerously low level. So I will use that one in people who have frequent low blood sugars or something called hypoglycemia unawareness, where they don't have symptoms when their blood sugar goes low. This is a good way to alert them that they're having a low blood sugar. The Dexcom does proactive alerts, meaning even if blood sugar is still normal, but it's starting to like go low fast, it will alert people so they can either treat it with some sugar or just pay closer attention to it. But a lot of people like the Libre a little better, just to kind of less alarms. It just depends, which is why I have people talk with the diabetes educators and to determine which one will work well for them. The other thing I will use these for is our diabetes educators offer continuous glucose monitor trials. So where people will go into their office, they'll get fitted with, it's a Libre, but they don't get any of the data or anything off of it at home. They just wear it around for, I think it's a week, maybe 10 days. So they wear it for that period of time. They don't do anything with it. They just keep it on. And then they go back at the end of the trial, and the diabetes educator gets all the data off of it and then sends it over to me. So I'll use that a lot when people are not on multiple insulin injections a day, but I'm worried that they're having frequent high blood sugars later in the day after they're eating that we're not seeing on their home numbers. For example, if their fasting blood sugar is always perfect at 100, but their A1C is 9, why is their A1C so high? I'll have them go do this continuous glucose monitor trial, and then it'll show us what their blood sugar is doing all day long, show us a pattern, and then give me some idea of what additional medication could we add that might help get them better controlled. I won't talk too much about these. I have not used them, but these are the newer, they're called patch pumps. So these are insulin pumps, but have been approved by Medicare for people with type 2 diabetes. So basically they hold insulin inside that little patch. And on the one on the left, that's the Vigo. That when you hit it, it delivers a small amount of insulin all day long, which would replace the long-acting insulin. So it's delivering some all the time. And then there's a button on it that you can push to give more, like before a meal or if your blood sugar is high. The one on the right is the Omnipod. So same idea, it holds insulin inside that pump. And then you set it up on the device that comes with it, what the dose is going to be that it's going to deliver all day long, and then what the dose is going to be that will be delivered for meals or if the sugar's high to correct it. So not something that I use a lot, but that is kind of an option that's there. I think they're both discarded at the end of each day, and then you start a new one. Questions about that stuff before I talk about the newest guidelines for type 2 diabetes management?
Sarah, no questions at this time. I am getting a number of questions about the recording of this presentation. Just so in the chat box, I put my email address, which is jwhoward, HOWARD, @med.umich.edu. If you have registered for this session and I have your email address, you'll get that in about a week anyway. But if you just want to make sure, feel free to email me with your email address. And I've taken a couple down already, just people who've sent me some messages through the Q&A. But that's it for now.
Okay.
Yeah.
So the last things that I'll talk about here are the newer medications, not insulin medications for type 2 diabetes management. So the shift right now in diabetes management is to focus not only on getting the blood sugars under control, but now focusing on reducing the risk of diabetes with these medications. So there's two different classes. They've come out in the last, gosh, I think the GLP-1s probably last 15 years and the SGLT2s probably in the last 6 or 7 years. And I'll give you some examples and you'll probably recognize some of them. But these medications are prescribed and used to help control type 2 diabetes, control blood sugars, but they also have shown to improve outcomes in terms of reducing the risk of complications. And I'll talk more in detail about each one. So the SGLT2 inhibitors, these are kind of the newest kids on the block for diabetes management. There were commercials, I haven't seen many lately, but Jardiance, Invokana, and Farxiga are the three that we prescribe most commonly. I use Jardiance and Invokana the most commonly. So they do lower blood sugar, not super drastically, but they do. But we're seeing a lot of benefits in people with heart disease and with kidney disease. So the kind of initial exciting studies, and when I first started working with the endocrinologists, these were really new. There was really good evidence about basically reducing the risk of death related to cardiovascular causes in people who had known coronary artery disease. So people who had known coronary disease, so who had heart attack in the past, had stents in the past, if they were put on this medication in the studies, the people who are on this medicine had less cardiovascular related death than the people who are not on these medications. There's also been shown reduced risk of stroke and reduced risk of heart attack when people who have known coronary disease were put on these medications. We're also seeing benefits in heart failure. So basically, it's reducing the worsening of heart failure, or reducing the risk of heart failure exacerbations, reducing the risk of hospitalizations from heart failure. And then we're also seeing really positive benefits for people with kidney disease. So people with known chronic kidney disease, we're seeing reduced risk of worsening of chronic kidney disease and reduced risk of death from chronic kidney disease complications. The other newer medications are the GLP-1 receptor agonists. So I gave a bunch of examples there. Trulicity and Bydureon that are on there are once weekly injections. Byetta and Victoza and Ozempic are daily or twice daily injections. And Rybelsus is the newest one that I have not prescribed yet. I'm not sure if it's really readily available or covered at this time. But that is actually an oral or a pill option for these medications. All the rest of them are injections. They're not insulin. They are used, again, they do lower blood sugar. These lower blood sugar a fairly decent amount, but we're using them a lot now, again, to reduce the risk of complications from cardiovascular and kidney problems. So in people with known cardiovascular disease, they again reduce the risk of reduce the risk of overall death and reduce the risk of death from a future cardiovascular event, so a heart attack or stroke. In people with known kidney disease, they slow down the worsening of the kidney disease. We also see improvement in blood pressure control, improvements in cholesterol, and these medications also offer some significant weight reduction for some of our patients. So pretty exciting stuff there. So since these medications have come out and since all these trials have come out with these newer medications, they have recently updated the guidelines for the recommendations in diabetes management. So the first line treatment for diabetes continues to be metformin. If you know somebody with type 2 diabetes, they've probably been on metformin before. That is still the gold standard medication. It is very affordable. Diarrhea and stomach upset is a common reaction, but otherwise it's pretty well tolerated and doesn't cause low blood sugars. So it's a good medication to start with. But if a second agent is needed because we're not getting good blood sugar control from just metformin, the newer recommendations now are to add one of those two classes of medications that I talked about. Unless the A1C is high enough where we need to start talking about insulin therapy, where we know we're not going to get good enough control with one of these medications, then we will add insulin. It's a pretty complicated regimen. There are instances where we would start somebody on insulin and one of these newer medications, but this is pretty exciting stuff where we weren't using these medications as second line agents before, and now that is the new guideline. There are really good indications to use these medications for those conditions that I talked about. I get messages all the time now from people's cardiologists and nephrologists asking if we can start them on one of these medications. I have some patients now involved in clinical trials with some of these medications. So they're studying these drugs for people who don't even have diabetes to see if there's going to be benefit for kidney disease and for heart disease in non-diabetic patients. So I think there's going to be really exciting stuff with these. We've already seen a lot of exciting stuff, but there's going to be a lot more exciting things to come. So keep an eye out. The problem with these medications and the reason why we often don't use them second line is primarily cost. So they are usually, at least one of these medicine in the class will be covered by insurance, but they are usually the highest tier copay. They're all brand name. They don't have generic options, so they're pricey. So that is often a reason why we will not use them. People can't afford them, don't want to bankrupt themselves on their diabetes medication, and there are other options that are much cheaper. These medications are filtered through the kidney, so we do have to pay attention to kidney function. So if somebody has moderate kidney disease, there are still indications to use these medications, but if the kidney disease becomes more advanced, more severe, then we are no longer able to prescribe them. So we do keep an eye on kidney function with these medicines. Some people, hands down, just do not want an injection. So that might be an instance where we wouldn't be able to prescribe them one of those GLP-1 medications. But there are instances where these medications are helpful, obviously for the conditions we talked about. But if somebody is really interested and wants a little bit of help with weight loss, that might be a good reason to start a GLP-1 receptor agonist, even if they don't have heart disease or kidney disease, just in terms of the weight loss benefit, that might be an option. Some of those GLP-1s are once a week. So for things like adherence, it can be really, really beneficial. If somebody just hates taking their medicines on a daily basis, but they're willing to take something once a week, then this might be a good option. Yeah, I think that's the bulk of what I had to say. Are there further questions?
Okay, Sarah, we do have one question. We have a couple questions. The first question is, so what's the difference between these newer categories? They seem to have the same benefits, yet they are from different classes.
The difference between the two? So I'm guessing that's what that means. So it depends. So I didn't put all the pharmacologic stuff in here, but basically they work on different pathways at controlling the blood sugar. So they work in different areas there. Let me go back. I can figure out how to do it. So the SGLT2 inhibitor is the thing that I kind of explain to people in layman's terms, is that they prevent the body from reabsorbing the extra sugar. So basically you pee out the extra sugar. So that would be one, it's a good thing to mention. That would be one kind of thing that people worry about with these medications. Is there initially were a lot of reports of increased UTIs and yeast infections because there's sugar being passed through the urine. I don't see it a ton in clinic. Yeast infections are pretty easy to treat. So if people do get them with this medicine, I will sometimes just give them a prescription for diflucan or something that they can take as needed. I haven't seen a ton of increase in UTIs. I'm not sure what the current data says about that in terms of frequency, but not something that's caused me to not prescribe them. because they pull extra sugar out through the urine, we do get some diuretic effect from these medications. So we do usually see some improvement in blood pressure. But for some people, we do have to watch for things like pushing the blood pressure too low, getting dizzy, lightheaded. So there are things to watch. The GLP-1s, they impact a pathway to help. I'm trying to think of the best way to say this, and I'm not a pharmacist, so it's not my area of expertise. But they work at a different point in the pathway in the same way as like a medicine like Januvia does. But these don't. The other thing that these do, and the reason why we see some weight reduction with them, is that they slow gastric emptying. So basically food hangs out in the gut a little bit longer, which is why we see people lose some weight with this, because there's some appetite suppression there. But not a good choice for people who have things like really chronic constipation, difficult to control constipation. There's been some links to some pancreatitis problems and people who have known pancreatitis, so we don't prescribe these medications in that instance. Or if people have really high triglycerides, that increases their risk of pancreatitis, so then we would get the triglycerides under control before we would prescribe this medication.
Okay, all right. Thank you for that, Sarah. The next question is, if they're beneficial for kidney failure, how come they can have kidney complications? A bit confusing.
So not kidney complications, but because the medication is processed through the kidney. So, most medications are either primarily processed through the kidney or primarily processed through the liver. These are processed through the kidney. So if they have more advanced kidney disease where their filtration rate is lower, then we don't prescribe these medications, because basically they're not filtering out the medicine. So we can get a buildup of the medicine, which can increase the risk of complications or problems from the medication. So they don't damage the kidneys. It's if there's already kidney damage there, then these medications wouldn't be filtered right, so we can't give them.
Okay, all right. Thank you for that. The next one says GLP recommended for weight loss.
So I think there has been some off-label use of it for people without diabetes for weight loss. Not something I am familiar with. I don't do a lot of weight loss management in the geriatric office. And not something I'm super familiar with, but I have heard that before. But I will, if somebody has type 2 diabetes, we need to improve their blood sugar control, and they have a goal to work on weight loss. If it's, if they meet the criteria for this medication and they want to try it, I have no problem with that.
Okay, all right. Thank you. There's another question I will type an answer for. The next one is, do they use other medications along with the GLP-1?
Oh, yeah. Yeah, I would. So again, usually people are on metformin first line, and then we don't usually stop any medicines, we add to it. So most people who are on this medicine are probably on metformin unless they were taken off of metformin for some complication or side effect they couldn't tolerate. Similarly, I have people who are on insulin 4 times a day, and I'll get a message from their cardiologist or their nephrologist, their kidney doctor, asking me to put them on this medication. So I have people who are on insulin multiple times a day that also take these medications because of those cardiac or kidney benefits.
Okay, and then the last question, a follow-up to that, is how much weight do people lose with the GLP-1 medication?
Oh, I can't remember exactly. It's nothing super drastic. I think it's under 10 pounds. So metformin, there is a common like 2 to 3 pound weight loss, maybe up to 4 pounds on metformin alone. And then with these medications, it's a little bit more than that, but it's still not, I mean, you're not going to drop 30 pounds if you start one of these medicines. It's like, they'll use it kind of, it's a good jump start to work on weight reduction, but it's not super drastic.
Okay, all right, very helpful. I do not have any more questions at this time. So I would say for everybody on this session, if you have follow-up questions, feel free to send those to me. I'm happy to pass those on to Sarah, who can get back with you after this. And I think that that's all that I had. Sarah, did you have any closing words before we wrap up?
I don't think so. I'll just scroll through here because I have my references at the end. So yeah, if anybody has questions, contact Jennifer. I'm happy to answer, do my best.
All right, thank you. Sarah, thank you so much for spending time with us today. This was really great information. I personally took a full page of notes on this session, so I really appreciate it. I learned all sorts of things I didn't know before today, so thank you. Thank you for everybody for attending. Again, the session is recorded and will later be posted on our website for the Turner Senior Wellness Program. And anybody who registered or who reaches out to me with their email address will have the link sent to them in about a week from today. So thank you all, and everybody have a great rest of your day.
All right, thank you.